Now I'm proud to announce that we have here with us a biker group from Italy. This is a tradition in Italy. Dodi has a meeting, MoMo, Morbid Mortality, that everybody presents the terrible cases, the most terrible cases, and we like them to come. They came here, and now we do some joint meeting with MoMo. And please present your the worst and the most terrible cases. Dodi.
Hello. Unfortunately, this is not a terrible case because my terrible stroke cases were in the early 2000s when I did them, and then when all this adventure on mechanical thrombectomy and stroke interventional procedures have come after 2015, I was too old to do that. So all my young colleagues were doing it, and so I did not do them, and then did not have complications. But so I looked for something, and I finally found I had a stroke complication, a ischemic stroke complication recently, but it was in a AVM case. So we have to go through a few slides with the AVM case. Okay, I got it. It was a 52-year-old man with a small posterior fossa hemorrhage, minimal symptoms, and you can see the hemorrhage there. With a few vessels around it. And so we did angiography, and angiography shows a slow flow AVM of the roof of the fourth ventricle. The main feeder is the left pica, and there are two draining veins. Here you see the two veins. One is going right, one is going left. These are two oblique views. One is going right, only the venous face, just to see the veins. So our next step usually is to discuss the case with the neurosurgeon, with the neuroradiosurgeon, and we discuss surgery, radiosurgery, and the vascular treatment. It's a small AVM. Their location is not too nice for the surgeon, but possible. Radiosurgery usually in hemorrhagic cases is secondary choice. So endovascular treatment, we don't believe too much in endovascular treatment unless it is a venous approach. So coming from the vein, there were two veins there, but well, endovascular treatment, and I said, yes, I can do it. It's for me. And I don't know if you know this guy. This guy is Tom Brady. He's one of the most winning person in American football. So I felt like Tom Brady. Yes, I can do it. I'm strong, and I'm experienced, and I'm good, and who else can do it if not me? And so just to see what was the AVM, here is a 3D reconstruction of the vertebral artery injection. And this is the artery getting to the nidus. And this is one single trunk of the vein. And then there are two veins coming out from that single trunk. So how could we do that? Arterial with glue, arterial with liquid embolics, or venous. As I said, the arterial approach to AVMs, I don't believe too much into it because usually we don't get the cure, even if they are small. So I said we should go venous. Is that a possible venous approach? I like it. So I said, yes, I can do it. This is a very nice case because I can really go through the veins to the nidus and then occlude the AVM. This is a beautiful ending of this treatment. Yes, I can do it. So I tried the venous approach. I tried to the left vein for a while. Didn't get there. Then I tried on the right vein for a while. Couldn't get into it. So I tried for a couple of hours to enter the veins, both right and left. I didn't understand why I couldn't, but of course I was not good enough, and unsuccessfully. So let's go to plan B. I'm there, the patient is there. I have plenty of catheters everywhere. Veins, no, then go through the artery. So I go to the artery, and you can see here with a sonic catheter in the pica. And the final result, I go directly to that. This is the injection of the onyx into the final part of the pica. It seems occluded. So finally, not what I wanted to do, but I get the result anyway. But it seems occluded. In fact, no, sorry. In fact, yes, the AVM is not there, but as you can see, I have a little problem with the basilar artery. Now there is a clot on the top of the basilar artery with the occlusion of the right posterior cerebral artery. So finally we get the stroke complication here, ischemic stroke complication. I have an embolic problem in the treatment of an AVM. It happens, fortunately not very often, but in this case it happened. So this complication in the past might have been a horrible complication. In the years I started working, it was it happened, and now we have an embolus in the artery. What can we do? But today we have plenty of experience with the treatment of acute stroke. So yes, we have an embolus. Let's go get it and take it out. But I'm not good at that. So it was time to change the team. Exit the offense. I should go out and enter the defense. And this is my friends and colleague Amedeo and Antonio, who come in with different team. And so I go out, they come in, and they do what they know how to do. So they have a fast aspiration of the clots in the posterior cerebral artery, and you can see that it's open. Very good result. But maybe you could see it. There is a little bit of stagnation in a small branch of the superior cerebellar artery. Who cares? Who cares? Would you care? So let's raise our hands. Who would go and try to reopen that small branch of the superior cerebellar artery? Okay, Camille, of course, yes, he would do anything in the brain. Anybody else? Or would you just leave it there? Okay, not see many hands up. Sorry? Intraarterial thrombolysis. It's an AVM that just ruptured. I don't know. Yes, you could do it. But I was out of the room, of course, and they, the two of young people, said, yes, of course we go there.
But there is also a problem that is a chief's complication, so you have to solve it.
Yeah, I'm there, and they think that it was me doing the case, and it's a case I did, so they should go for the perfect result. Yes, so they go for it, and they use a mini catch, and they canalize it. They're very good, so everything is open again, wonderful. So he is discharged in fairly good conditions. AVM is cured and vessel open. We feel like winning champions. Yes, we did it together. This is the way it should go. We are a team. Everything goes well. So now it's time to look at the 6 months follow-up. And of course, there is a stroke where the pica was occluded. Maybe you can see it, the veins are still there. So the AVM is not cured. So is this a complication? Well, it is a complication of the AVM treatment. But the most important conclusion are that I was not able to enter the veins from the sinus. I was not able to occlude the AVM from the artery. I had a complication that someone else resolved. The patient now has some less cerebellum and still holds the AVM. So what is the moral of this story? Boo! Thank you very much.
And what is the strategy for the AVM now?
I thank you for this question. So he came back for the maybe 1 year or 2 years follow-up recently, and the AVM is still there as it was after the first control. So we have sent the patient to gamma knife.
So one more question for AVMs. So do you usually treat them immediately after the bleeding in a case that you don't see the pseudoaneurysms inside, or wait a few days when the bleeding is reabsorbed and reach them?
Is this the topic for this meeting? AVM treatment? I don't know. But if you, it depends, of course, on the bleeding. If it's a big bleeding and we don't find the source of the bleeding, we might wait, or it goes to surgery, of course, you have to evacuate the hematoma. If it's a big bleeding in the ventricles, you do whatever you need to do in the ventricles. So usually we do emergency treatment only if we find the point of rupture of the AVM, which is endovascular. So that we think that once you have occluded that, you are in a more quiet situation and you can just wait, like if the AVM was an unruptured AVM, and you can proceed with the program could be surgery, could be radiosurgery, whatever. Sometimes you have a big bleeding and you still have the AVM there, you don't know what bled. If the AVM is small enough, you might go for immediate treatment just so that you can take care of it. But I don't like to do partial embolization of an AVM if you don't know what to occlude.
Thanks.
So, but going back to ischemic stroke, it looks like it's not an issue anymore. I mean, even if you don't have Antonio and Amedeo, but which would be good, but the occlusion, unpredictable occlusion of arteries can be managed quite quickly. I mean, that's what they did.
Yeah, that's what was the point mostly of this presentation, that something that years ago would have been a terrible complication. Now today it's like, oh, who cares? Now we know how to take an embolus from an artery, and it's easy, and we have the materials, we have the techniques, so everything has changed in our perspective of ischemic complication during treatment of vascular malformation. Could be also aneurysms and things like this. So yeah.
Thank you, Dodi.